Right now in the UK, if you want to operate a forklift, you actually need to undergo specialized training, right? Like you have to hold a license.
Right, which makes total sense.
Yeah, exactly. But if you want to inject a prescription neurotoxin directly into a human face,
You legally don't need anything.
I mean, it's wild. You can literally just walk off the street,
Yeah.
set up a chair somewhere, and start injecting.
It sounds completely like an urban legend, but
Yeah.
that is the actual current regulatory reality. I mean, we all just kind of assume there's this massive safety net governing who gets to, alter our appearance.
Yeah, sure.
But that net is just riddled with holes right now.
So today we are going to explore this massive and frankly somewhat terrifying gap between these incredible medical advancements we have now and the law.
Yeah, it's a big one.
And we are pulling from a really diverse stack of sources for this deep dive. We've got clinical textbooks that detail the microscopic precision you need for skin biopsies.
Which is fascinating on its own.
Right. And then we have a cutting-edge medical white paper on treating pigmentation, specifically looking at darker skin tones. And to top it all off, we are unpacking this massive set of UK government consultation
The
documents.
proposed laws.
Yeah, detailing the proposed laws for this booming multi-billion-dollar cosmetic procedure industry.
The goal here is really to give you, the listener, an absolute insider's view of an industry that is, simultaneously producing medical miracles and operating entirely like the Wild West.
It really is the Wild West out there.
Because, before anyone can safely vaporize a sunspot or smooth out a wrinkle, there is a fundamental non-negotiable step.
You have to make absolutely sure that spot isn't trying to kill you.
Exactly. Safety first, always.
So let's start right there on the diagnostic front line. Say you're looking in the mirror and you spot a mole that just, I don't know, it just looks suspicious.
Right. Something feels off.
You go to a dermatologist. And before anyone even thinks about aesthetics, the doctor is going to run through the ABCDE criteria. What is actually happening in their mind during that visual check?
So they are looking for specific warning signs of melanoma. It's a checklist. A is asymmetry. Basically, if you draw a line right through the middle, do the two halves match?
Okay, how that gets say.
Then B is for irregular borders. C is for multiple colors within the exact same spot.
Like if it's brown and black and red all at once.
Exactly. D is for a diameter greater than 6 millimeters. And E is evolution.
Evolution, like is it changing?
Yeah, is this thing actively changing shape or size? That's a huge red flag.
But wait, we have all this incredible technology now, right? I mean, you see ads for like AI apps that scan your skin.
Oh, everywhere.
Yeah, or those dermoscopy tools. Don't those essentially just make the diagnosis for the doctor at this point?
You'd really think so, right?
Yeah.
Especially considering how heavily they are marketed to clinics. And tools like dermoscopy do give a highly magnified, polarized structural view of the skin. And algorithms like Melifine, they can certainly analyze a spot against a massive database. But the clinical textbooks in our stack are very, very clear on this. These tools are adjuncts.
Meaning they just help?
Exactly. They might flag a concern, but they absolutely do not replace clinical judgment. A seasoned physician's eye and their experience, that remains the gold standard.
Okay, so let's play this out. The doctor looks at your spot, they don't like what they see, and they decide, okay, we need to do a biopsy.
Right.
And reading the sources, this isn't just a quick sniff and you're done. The prep alone is highly calculated. The textbooks detail injecting this specific concoction. It's 1% lidocaine mixed with epinephrine.
Yes.
Now, I know the lidocaine numbs the pain, obviously, but then the doctor just sits there and waits for like 7 to 10 minutes before doing anything at all.
It's true.
I mean, it seems like an absolute eternity when you're a patient sitting on crinkly paper anxious about cancer.
Oh, it feels like a very long time. But that waiting period is crucial, and it's entirely because of the epinephrine.
Okay.
Because epinephrine is a vasoconstrictor, its literal job is to shrink the surrounding blood vessels to minimize bleeding during the procedure. But, it's a biological mechanism. It takes time to kick in.
Ah, I see.
If the doctor rushes in immediately right after injecting, the area is just going to bleed heavily. That obscures their view and makes the removal way more complicated.
So it's literally a game of patience.
Exactly.
And once the spot is finally removed, stopping whatever bleeding is left is just as delicate. The texts specifically warn against using certain iron-based liquids, right? Like Monsel's solution.
Right. And Monsel's solution is a highly effective coagulant. It stops bleeding fast, but it comes with a massive diagnostic cost.
Because of the tattoo it leaves.
Yes. When it interacts with the tissue, it leaves this residual light brown artificial pigment behind right in the dermis.
The sources literally call it the Monsel tattoo.
They do. And imagine this scenario, okay? The biopsy results come back from the lab. It actually is melanoma, and the surgeon needs to go back in to remove a wider margin of tissue.
Oh, wow, okay.
If they used Monsels originally, that artificial brown pigment makes reading the new pathology under a microscope incredibly difficult.
So you are basically muddying the waters of your own future diagnostic tests.
Exactly. You're making it harder to save the patient's life, essentially.
That is wild. Which brings us to the actual physical removal of the spot. According to the textbooks, doctors usually face a choice between two things: a shave biopsy.
Also known as saucerization.
Right. And an excisional biopsy.
Right.
Let's talk about the shave biopsy first because, from a patient's perspective, it honestly sounds ideal.
Oh, it is incredibly popular for a very good reason. The doctor essentially takes a horizontal slice, just removing the raised portion of the lesion.
Right, so it's super fast.
It takes minutes, and it leaves a very shallow, cosmetically appealing scar that often just fades beautifully over time.
So it's kind of like mowing a lawn.
Wow.
It's fast, the surface looks pristine, and it's great for curbing a patient's immediate anxiety because they don't see the spot anymore.
That's a great analogy.
But just like mowing a lawn, you might leave the roots of the weed entirely intact underground.
And that is the absolute nightmare scenario for a dermatologist. Because if a doctor performs a shave biopsy too superficially on a suspected melanoma, they risk transecting the base of the tumor.
Transecting meaning they just slice right through it.
Yes, they slice the top off the cancer and send it to the lab, but they leave the bottom half hidden inside the patient.
And if they do that, the pathologist in the lab can't determine the Breslow depth, right?
Exactly.
Because if we stick with the weed analogy, you have to know exactly how deep the taproot goes to know what kind of chemical weed killer you need.
That's spot on.
If the pathologist doesn't have the whole root, they literally can't accurately stage the cancer.
And without that Breslow depth, the oncology teams are just flying blind. They don't know how aggressively they need to treat the patient. This really perfectly illustrates the central tension in all of dermatology.
Which is what?
The doctor is walking a perpetual tightrope. On one side, there's this desire to give you the best cosmetic outcome, a tiny invisible scar. But on the other side is the absolute need to ensure medical safety by taking a wide, deep margin.
Wow. Okay, let's pivot a bit. Let's look at a scenario where you actually clear that medical hurdle. The lab calls, the spot is totally benign.
Huge sigh of relief.
Yeah, you breathe a sigh of relief. But now you just want it gone because you honestly don't like how it looks. Maybe it's a sunspot or age-related pigmentation.
Sure.
You'd think removing a benign spot would be super simple. But the medical white paper in our stack reveals that cosmetic removal comes with severe risks, particularly if you don't have fair skin.
This has been a critical and honestly often overlooked issue in modern aesthetics for decades. We are talking about patients with Fitzpatrick skin types done through 6.
Which encompasses darker, melanin-rich skin tones.
Correct. When practitioners use traditional resurfacing lasers like a CO2 or an erbium YAG laser to remove pigmentation on these skin types, it frequently triggers a really severe complication.
Post-inflammatory hyperpigmentation.
Yes.
PIH.
Yes, PIH.
The statistics in this white paper are just staggering. For patients with the darkest skin tones, almost 100% experience severe hyperpigmentation anywhere from 6 weeks to 6 months after traditional laser ablation.
Almost everyone.
I mean, if you go to a clinic specifically to remove a dark spot, and you are basically guaranteed to leave with a much larger, darker patch of pigment,
Yeah.
why is that happening biologically?
It really comes down to what melanin is biologically designed to do. Melanin's job is to absorb energy, specifically UV light, to protect your skin.
Okay.
Type V skin absorbs up to 40% more visible light laser energy than lighter skin. So when a traditional hot laser hits that skin, the melanin just absorbs all that excess thermal energy.
Right.
And that heat causes surrounding tissue damage, which the body immediately interprets as trauma.
So the skin basically goes into defense mode.
Precisely. The trauma triggers the melanocytes to just flood the area with even more pigment, trying to protect the injured skin. So the treatment itself causes the exact problem it's trying to solve.
That is so frustrating. But the sources highlight a massive technological leap that is finally trying to fix this.
Yes, the new laser.
Right. It's called the ultra-clear 2910 nanometer erbium-doped fluoride fiber glass laser. which is quite a mouthful.
It really is.
And the white paper claims it uses proprietary cold ablation technology. And I just have to pause here, because cold ablation sounds like a total marketing paradox.
It does sound like an oxymoron.
Yeah. How does a laser, which is literally shooting intense beams of light energy, vaporize human skin cells if it is cold?
It is a brilliant piece of physics, honestly. And just to clarify, cold doesn't mean the laser is shooting ice or something.
Okay, good to know.
It means the technology prevents thermal transfer to the surrounding tissue.
So wait, is it like, when you pass your finger through a candle flame?
Oh, yeah.
If you move your hand really slowly, the heat transfers and you get burned. But if you swipe your finger through the flame in a fraction of a millisecond, you don't feel a thing. The energy simply doesn't have the time to transfer into your tissue. Is that essentially what this laser is doing at a cellular level?
That is a perfect analogy. That's exactly it. The ultra-clear laser delivers highly targeted energy so incredibly fast that it vaporizes the specific target cells before the heat has time to bleed outwards.
Wow.
And because there is no excess heat bleeding into the surrounding skin, the melanocytes never register a thermal trauma. They just stay dormant.
Meaning no hyperpigmentation.
Exactly. No PIH.
The clinical case studies attached to this paper are just phenomenal. There's Dr. Amy Vyas, who treated superficial pigmentation in a Fitzpatrick type V patient.
Right?
And Dr. Erica Linnell, she treated a Filipino patient with type 5 skin who had actually tried and failed 2 traditional CO2 laser treatments previously.
Which is a tough case.
Yeah, and both doctors used this new cold ablation, and both saw marked reduction with 0 post-inflammatory hyperpigmentation.
Achieving 0 PIH in a patient who previously failed a traditional CO2 treatment is a huge landmark result.
Yeah, I bet.
For decades, highly effective laser treatments were predominantly safe only for lighter skin tones. That effectively locked a huge portion of the population out of top-tier dermatological care.
That's so unfair.
It is. But this technology is finally bridging that gap.
It's an amazing leap forward. But, here is the terrifying paradox of all this innovation.
Yeah.
We've just spent the last 10 minutes obsessing over the microscopic precision required by a doctor to biopsy a root, right? And the exact nanometer physics of a cold laser.
Very precise science.
Science is flawless.
Yeah.
Yet when we transition over to the massive stack of UK government consultation documents, we find out that the person holding that laser or holding a syringe of dermal filler, they might have absolutely 0 medical training.
The contrast is completely jarring. The Medical Defense Society explicitly describes the UK's cosmetic market as a Wild West.
Which is not what you want to hear about medicine.
No, not at all. Currently, there are an estimated 16,000 businesses providing non-surgical cosmetic procedures across the UK. And yet, there is no standardized legal requirement for practitioners to hold a medical qualification before injecting substances into your face.
And the stakes here aren't just getting a bad result that looks a little lumpy, right? The consultation documents explicitly cite GPs treating horrific complications.
Really terrible stuff.
Yeah, permanent nerve injury, tissue necrosis, blindness. They also mention the tragic, high-profile death of Alice Webb, who died following a non-surgical Brazilian butt lift.
It's awful.
This isn't just vanity gone wrong, it's a public health crisis. So how is the government actually proposing to fix it?
Well, they are proposing a massive regulatory overhaul through a 3-tier licensing system, basically classifying every single procedure based on its potential risk of complication.
Okay, let's translate these tiers for the listeners. Tier 1 is green, the lowest risk. What falls under green?
Green includes procedures like microneedling, IPL lasers, and no needle fillers. Under the proposal, any practitioner who meets newly agreed-upon training standards can perform these legally.
Okay, that seems pretty reasonable.
Yeah.
Then we step up to the amber category, medium risk.
Right.
This includes Botox, facial dermal fillers, and weight loss injections. The proposal states non-healthcare professionals can still perform these, but only if they are licensed and working under the oversight of a regulated healthcare professional.
Exactly. And finally, the red category, the highest risk.
What's in that one?
Thread lifts, breast and buttock fillers, deep chemical peels. The government proposes pulling these entirely off the high street, restricting them exclusively to Care Quality Commission or CQC-regulated healthcare professionals.
What's wild to me is trying to figure out where the brand new tech even fits in all this. Like we just talked about the ultra-clear laser. Where does that go?
That's a great question.
Is it green because it's just a laser? Is it amber because of the depth it can reach? Or red because it's literally vaporizing skin? The technology is evolving so fast that the ink is dry on the legislation before the new machines even hit the market.
You've hit on the core problem right there. Categorizing thousands of different devices and injectables into 3 neat little buckets is just a logistical nightmare.
And it has sparked an absolute civil war within the beauty and medical industries. The government consultation received over 11,800 responses.
They were very fired up.
Let's actually look at the friction here, because both sides have incredibly passionate, valid arguments about public safety and their professional livelihoods. We have to look at both sides impartially. Let's role-play this a bit.
Okay, sure.
I'll take the side of the aesthetic practitioners, so the non-medics, and you take the side of the healthcare professionals.
Let's do it. From the medical side, the argument is straightforward. Any procedure involving skin penetration or prescription-only medicines, like a neurotoxin, is inherently medical. It is minor surgery. Healthcare professionals point to their years of clinical accountability, their comprehensive anatomical knowledge, and crucially, their ability to manage a crisis with prescription emergency medications.
Okay, but as a non-medic aesthetic practitioner, I'd argue that tying safety to a general medical degree is totally biased.
How so?
Well, say I'm a beautician with a level 7 qualification specifically in injectables. I've spent 2 years doing nothing but studying facial anatomy and practicing filler techniques. Why should a GP or a dentist who might have only taken a 1-day weekend course in Botox have more legal right to inject a forehead than I do?
That's the argument they make. But from the medical perspective, it's not just about knowing where to place the needle, it's about the chemistry of an emergency.
What do you mean?
If a dermal filler accidentally blocks a blood vessel, a vascular occlusion, the tissue on the patient's face will literally begin to die. Or they could go blind.
It's terrifying.
Right. And a prescribing doctor or nurse can instantly write a script for hyaluronidase. It's an enzyme that dissolves the filler, and it resolves the emergency in minutes.
Oh, I see.
As a non-medic, you cannot legally hold a stock of that emergency drug.
Wow, okay. That is a really compelling point about the emergency response. But this brings us to what seems like the most contentious part of the whole proposal, the amber tier.
Yes, the oversight issue.
Right. The government says amber treatments, like those fillers, need oversight by a medical professional.
Yeah.
But what does oversight actually mean in practice? Like, does a doctor have to physically stand in my treatment room watching me inject every single patient?
That ambiguity is exactly what generated thousands of furious responses. Does oversight mean being in the building? Does it mean the doctor is available on a Zoom call from a golf course?
Right.
And the lines get even blurrier when you look at borderline products.
Oh, like lemon bottle fat dissolving injections?
Yeah.
They've completely blown up on social media lately.
Yes, perfect example.
Technically, they don't contain prescription-only medicines. So under these proposed rules, why should an experienced beauty therapist suddenly need a medical license and clinical oversight to use a product they've been using safely for years, while a nurse can just set up a clinic with no extra aesthetics training?
The attempt to draw a hard line is just creating massive regulatory loopholes. And there is one more major component to this proposed legislation that we really need to touch on: age restrictions.
Right, the under 18 ban.
Yes. The proposal wants to strictly ban these licensed procedures for anyone under 18.
Now, on the surface, that sounds incredibly sensible. I mean, teenagers are constantly bombarded by social media filters, their bodies and brains are still developing, and they definitely shouldn't be getting lip filler for prom.
Absolutely.
But the consultation documents highlight some really nuanced medical caveats where a blanket ban could be pretty devastating.
We have to remember that these tools aren't just for vanity. There are young people suffering from severe medical conditions where these exact treatments are life-changing.
Right. If you think about a teenager with deep, cystic, scarring acne, a chemical peel or a laser treatment isn't a luxury. It's a medical intervention.
Exactly.
Or consider a young woman with polycystic ovary syndrome, PCOS, suffering from excessive dark facial hair. Laser hair removal could provide immense psychological and physical relief during a really vulnerable time in her life.
And to be fair, the legislation does attempt to account for this. It proposes allowing these procedures for minors, but only if a doctor explicitly signs off on it for a recognized medical or psychological condition.
Well, we have covered incredible ground today. We started by looking at the terrifying microscopic stakes of a skin biopsy, the difference between a clean shave and leaving a deadly taproot behind.
Important stuff.
And then we explored the physics of cold ablation lasers, finally democratizing safe pigmentation removal for darker skin tones.
Truly game-changing technology.
Yeah, we followed that science out of the lab and into the sprawling, high-stakes political battle over who actually gets the legal right to hold a needle.
Because it all comes down to one core philosophical question the UK government is trying to answer. Is altering the human body with injectables and lasers a beauty treatment, akin to getting a haircut, or is it a medical procedure, akin to minor surgery?
The government is trying to split the difference with this tiered system, but the reality on the ground is messy, it's tribal, and it is evolving by the minute.
It really is.
So the next time you walk past a brightly lit window on the high street offering lip fillers, fat-dissolving shots, or laser treatments, you now know exactly what is happening behind those doors.
Yeah.
You understand the clinical risks, the medical miracles, and the fierce regulatory war trying to govern it all.
Be careful out there.
But I want to leave you with a final thought to ponder. As these cosmetic procedures become more common, more affordable, and as technology like cold ablation continues to eliminate the physical risks of scarring, will the very definition of natural beauty fundamentally change? If you are growing up in a generation that has never known a world without cheap, accessible, risk-free aesthetic tweaks, what will natural even mean to you? It's clear that the skin isn't just a canvas, it's a living, breathing battleground, and the qualifications of the artist holding the brush matter more than we ever realized.